Welcome viewers to the teleconferencing for the certificate program in healthcare waste management, and I take this opportunity to welcome the experts for this teleconferencing sitting here. On my immediate right is Mr. Alexander von Hildebrand. He is the regional advisor, WHO regional advisor, environmental health, WHO Southeast Asia regional office, and all of you probably have read the material which has been sent to you, the course material, and let me tell you that Mr. Alex has made invaluable contribution in the planning, in the development, in the launching of this certificate program in healthcare waste management in India and in all the Southeast Asian countries. And then on my extreme right is Dr. Megha Rathi. Dr. Megha Rathi is an expert in the environment health and more in the healthcare waste management. She did her PhD, and her PhD topic has been on the healthcare waste management. I welcome both of you for this teleconferencing. I also welcome some learners who are sitting in the studio, who have come from one of the program study centers in Delhi itself, and we will start with the presentation. What we will do, that we will have two sessions, long sessions. We will go on up to 3:30 immediately, and then from 3:30 to 3:45 we will have a small break, and then again from 3:45 to 4:30 we will have the last session. So this is how we will schedule our timings, and in the first session I will make the introductory presentation on the classification of waste and the general principles in the healthcare waste management, and then I will request my friend Mr. Alexander von Hildebrand to give a perspective about the regulations and legislation with regard to healthcare waste management in India and some of the Southeast Asian countries. So let's begin with the first presentation, which is the waste classification and disposal options. And here I would like to give you the classification of the healthcare waste management as described by WHO and also as described by the Indian under the by India under the healthcare waste management and handling rules. So this, as you know, healthcare waste, we should be clear about what is the healthcare waste, and here we are describing that any waste which is generated during the diagnosis, treatment and immunization of human beings or animals, in research activities pertaining thereto, or in the production or testing of the biologicals. So this is a very broad definition, which we should be very clear that it is the diagnosis, treatment, investigation, research activities on the human beings as well as on the animals. But we are talking of the hospitals and health centers, so we'll confine more to the waste generated as a result of the diagnosis, treatment and investigations in the healthcare settings, ranging from the lowest and most peripheral health centers up to the most tertiary and sophisticated hospitals. And this is a slide which shows you the various sources of the healthcare waste, and here we see that the hospitals are number one, which contribute significant volume in healthcare waste. Then we have all the other settings which are described here. I will not go through each one of them, but you can have a look yourself that all kinds of healthcare settings and diagnostic facilities are included here, including the blood banks, the mortuary, the dental centers and animal houses. The WHO has given this classification, in which they have classified into 9 or 10 types of the waste. Number one is the infectious waste. The infectious waste, as you know, it's given under the example, is the waste which suspected to contain pathogens from laboratory culture, waste from isolation wards, tissue material, equipment, and the equipment that has been in contact with infected patients and excreta, etc. Second category is the pathological waste, which includes the human tissues or fluids, for example, body parts, blood and other body fluids, fetuses, and other, anatomical waste. Then third category of the waste by WHO is sharp, and sharps are very important and very dangerous actually. And I would, when you go through your, you see blocks, course material, you will find quite a big emphasis on the patient safety and the issues which are dealing with the sharps management, because sharps cause a lot of serious infections, and as healthcare professionals, you know that we have problems like hepatitis B, C, and then the HIV and other infections which are as a result of the improper management of the wastes. So this is very important category in the entire scheme of things in the healthcare waste management. Number 4 is the pharmaceutical waste, and as the name indicates, this is all kinds of pharmaceuticals, expired drugs, etc. Genotoxic waste is the fifth one, waste containing substances with genotoxic properties, and Okay. Sorry viewers, there was interruption because of the power breakdown. We were talking about the classification of the waste as per the WHO classification, and we had gone up to number 5, which is the genotoxic waste. And in the genotoxic waste, we were saying that it is the waste containing the substances with genotoxic properties, for example the cytotoxic drugs and the chemicals. And we come to the next category of the waste, and that is the chemical waste. And the chemical waste, as you see here, is described on the table. Can we see the table, please? This is the laboratory reagents, film developers, and other chemicals used in the hospital and in laboratories. Next is the waste with high content of the heavy metals, and these are the batteries. Please keep the slides focused. Yes, and yes, we have the waste with high content of the heavy metals like the batteries, the broken thermometers, and the BP instruments. This is the number 7, as you can see on the screens. And the next is the pressurized containers. As you know, these are the various aerosol cans, and the gas cylinders. And here the last waste which is described in the WHO classification is the radioactive waste. Is last? Yeah, that's the last in the. This is the radioactive waste. As the name indicates, you know, it's very potentially dangerous, very hazardous waste, and there are guidelines given by Bhabha Atomic Research Center, and we have the radionuclides, we have the source which are used in the cobalt machines, then we have the brachytherapy units, we have various, you know, sources from where the radioactive leaks can take place. So we have to be very careful in the hospitals which are using the radioactive isotopes and the cobalt machine or the brachytherapy and all these things. So this is the classification which has been described by WHO. Next we see now Indian classification. Now this is, you know, the India has come out with the biomedical waste management and handling rules 1998, and these rules describe and classify the waste into again 8, 9, 10 categories, and these are number 1. They are very similar, but you know, even then it's good to remember both, or good to know about both the classifications. Again, category 1 is the human anatomical waste, and how it is, what treatment can be given and how it is disposed of, that is also indicated against each type of waste. So human anatomical waste, as you can see here, should be destroyed by incineration or deep burial. That is the best option for the anatomical body parts and other related, you know, excised tissues, biopsy tissues, etc. The second category again is called as human waste, but that may include animal tissues, the organs, body parts, the carcasses, bleeding parts, the fluids, body fluids like blood and other amniotic fluid, etc., and experimental animal used in the research. So all these things, you know, will come under the human and animal waste, which is again the classification will be same for this. I mean the treatment option will be same for this. Category 3 is the microbiology and biotechnology waste. As the name indicates, you know, this is the waste from the laboratories basically, and here the best option would be to autoclave this waste which is there from the laboratory, like cultures and other things, or microwave. And finally we can also do the incineration, but you know, it is better to use environment friendly techniques, so autoclaving and microwaving should be preferred over the incineration. Then we have next category, which is sharp. I have already mentioned about that. Most important thing in the sharp is that we have to you know, disinfect them, and the best disinfectant that we normally describe is the sodium hypochlorite solution, 1% to 2%, and then we can you know, discard these sharps in that, and then later on they can be mutilated and shredded or deep buried. Then we have next category, category 5 is the discarded medicines and the cytotoxic drugs, and again same thing like pharmaceutical waste in WHO classification. Then category 6 is the actually soiled. It is not solid, so it's right, soiled waste. That means items contaminated with blood and body fluids, excreta, etc. So these soiled waste, is again very infectious. So best would be to autoclave or microwave them before we send them to laundry. Incineration actually as a last resort in case you don't have the autoclaving and microwave facilities. Seventh category is the solid waste, that is the waste generated from the disposable items. We have so many disposable items which includes the plastics, the tubings, the intravenous sets, etc. This also should be disinfected through chemical treatment or by autoclaving and microwaving. The last three categories in this liquid waste, and we know that the waste from laboratories, the blood bank, other operation theatres. So the liquid waste management in fact has been a very weak link all over, and especially in this country we have the corporate hospitals, we have the 5-star hospitals, but they will have good facilities for the waste management like the other categories, but when it comes to the liquid waste management, you will find rarely the best of the hospitals will have the effluent treatment plants for the liquid waste management. I think this is one area which increasingly is now should be given importance in the entire scheme of the things when it comes to the biomedical waste management, because liquid waste management is just very carelessly being discharged into the drains, and then it pollutes the entire water resources wherever the water is going out. So this is a very serious lacunae, and I think the Central Pollution Control Board also has to be very strict in the regulations with regard to very strict rules that hospitals, before they are given the licenses, especially the city hospitals, bigger hospitals, multi-speciality hospitals must have the effluent treatment plant. I and Alex, my friend, we both were there in Indonesia, and we are very happy to share with you that in Indonesia, isn't it, Alex, that most of the hospitals had the effluent treatment plant in the hospitals, and they were managing their liquid waste management in a very nice manner, which we visited. But in this country, probably this is one of the weak links, isn't it, Megha? You also feel the same way, because liquid waste management has not been given importance.
Not as much.
Yes. The category 9 is the incineration ash, because incinerators are still being used in this country and probably may continue to be used for some more time. So the ash which comes out from them, sometimes it is half burnt, not properly burnt articles, items, and this ash is also may be very dangerous because of the various reasons, including the heavy metals which may be there in the waste, in the ash. So this best way would be to send them for the sanitary landfills, or the deep burial. The last category is the chemical waste. Again, we have discussed in the WHO classification. There are various chemicals, and they have to be taken care of. Another very important thing, if you see this slide and this diagram, it's very important diagram, because our learners have to be informed about thing. Out of the total waste in the hospitals, it is only very small percentage of the waste which is hazardous, infectious, and that is around 15 to 20% of the total waste. Nearly 80 to 85% of the hospital waste is not infectious or hazardous. So the segregation at the point of generation becomes the most crucial issue in the entire healthcare waste management, so that this 15 to 20% of the waste can be separated from the non-infectious waste, which could be from the kitchen, which could be from the consumables, which can be from disposables, which could be from stationery. There are and this 80 to 85% of the non-hazardous waste can be recycled, can be reused, can be composted. There's so many things. So I think this has to be the underlying principle in the entire healthcare waste management, that we must try to segregate at the point of generation. And you will see that the soiled linen or the soil dressings, the sharps, the body parts or the laboratory waste or the radioactive waste, this will not be more than 15 to 20% of the entire waste. And if we are able to take care of this 15% or 20% of the waste, then the battle is won with regard to the hazards associated with the healthcare waste management. What is happening? There is another danger where my friends, the experts will share with me, and we have been to Nepal, we have been to Bangladesh, and also in Indonesia, Alex, that some hospitals are doing segregation at the point of generation, but when it comes to the final disposal, the entire thing is mixed up in the big bin. And we have got the photographs, isn't it, Alex? So, what is happening, that at the end point, the municipal dumps are there, or some other, bins are there. So, this waste, 15% which is segregated at the point of generation is mixed up. So, what happens? The entire 100% waste becomes contaminated. So, please, this is the very important thing. It should not be only at the point of generation that you segregate this dangerous waste, but you must see it to the final treatment and disposal option separately for this hazardous waste. Would you like to say something on this, Alex? Because this is a very crucial issue in especially the Indian and Southeast Asian countries. Any comment?
Yes,
please. Yeah. No, the same mic. Yeah, you can
same
use
mic.
this. Yeah, same. That's okay. You catch your voice.
Yes, Ashok, two things on that. You mentioned the liquid waste. It is a challenge, and I would like to inform you all that there will be a specific meeting on this early May in Bangalore.
Bangalore.
But it's focusing on best ways to handle the liquid waste
GTZ,
from hospitals. Yes, with the GTZ. The other one is if motivated hospital staff does go for implementing a segregation system, sound management of healthcare waste, if then they see that the segregated waste is again mixed before it leaves the hospital or as it leaves the hospital, that is of course the best way to take away all the motivation that has maybe taken you months or maybe years to bring up. So it is very crucial that we understand it is key to have one system functioning in the particular health center, but it needs to be coordinated with municipality, for instance, or with other health centers in the locality, because if not, it won't take long until it collapses again.
Thank you, Alex. Thank you. Yeah, Megha, would you like to make a point here?
It's the same thing which Alex said, that the motivation that's there within the healthcare workers just goes off if the waste is segregated by them and then mixed by the final authorities, the ones who are picking up from the hospitals. So it's not only the hospitals, I guess, but as Alex said, the municipal authorities who also need to be trained on this, and the centralized facilities that are coming up nowadays.
Yes, thank you. And that's where the importance of this program, our certificate program in healthcare waste management becomes so crucial. And it's very unfortunate that despite so much of our efforts, despite the efforts by the World Health Organization Southeast Asia Regional Office, we see that the hospitals are not coming forward to sponsor their health professionals for undertaking this program. This is something because probably they don't see any career in this, but I think this is a grey area, and I would urge upon whosoever is listening or happens to see this recorded video again, teleconferencing, that we must take this issue very seriously. There is a need to increase the awareness among the health professionals, especially the hospital people who are involved in the entire healthcare waste management in the hospitals and health centers. Now let's look back. Let's look back at the slide that is there, and so I will just show it again to you, that it's the red triangle which shows only 15% of the waste which is hazardous. And we'll move on to the next one, and this point I have already mentioned, underlined this. Segregation at the point of generation is very, very important, and this segregated waste should be looked after till the final treatment and disposal option, so that it doesn't get mixed up with the non-hazardous waste. That is very, very important. Sharps management has been given a special attention in my presentation. I've already mentioned so much about it that these are very potentially dangerous waste from the hospital. We need to be very careful, and these are the things which I have mentioned in the bulleted presentation here. Never recap the used needles, never pass used sharps from one person to another, locate the needle destroyers and container needle near the point of generation, and disinfection of the used sharps in the puncture proof container. PPC means puncture proof container. This is very, very important because they are sharps, and the disinfectant that I told you, sodium hypochlorite 1 to 2%, should be contained and should be prepared every day fresh in the puncture proof containers. Now this is one type of the needle and syringe destroyer manual. We have the electrical also, so at least that should be there, and we should have the some in the buffer stock to because they go out of order very fast. That is one problem. Now this is the color coding which is described here, but in your blocks we may have a different scheme of things, but you go by the color scheme which is given in your course material. And but universally, yellow bin, yellow bags are for the most dangerous waste, which is the body parts, the human anatomical organs, fetuses, other microbiological waste, cytotoxic waste. All this should go into the yellow bins, and that normally we send for the incineration or the burial. And red bin is actually for the waste for non-incineration treatment disposal, but they are also infectious, so we can have other options. White bin has been described here as waste requiring no treatment, like paper, packaging, packaging material, cardboard, general waste, etc. Green bin, as you see here, is for the kitchen waste, etc., food waste, and blue bin is for the sharps. So this is the scheme of color scheme which is shown here. This is the transportation. You can see internal transportation and external transportation. Internal is, of course, we can have different. These are the colored bins which are shown in black and white only. Different color bins are transported from the point of generation to the curb area in one corner of the hospital, from where they are disposed of as per the classification. External transport can be seen here. These are the we have some central treatment facilities in number of metro towns, including Delhi, Bangalore. Bangalore has got 2 of them, and these are the vans which go to the hospitals, collect the waste, and the hospitals pay them per kg basis or whatever be the system, and they take the waste to a common treatment facility for the final disposal. And these are the various final treatment and disposal options. Incineration, though, is on top, but should be the least preferred method of disposal because of the dangers involved. I am not going to cover that. Autoclaving is environment friendly. Microwaving is environment friendly. Chemical disinfection, secured landfill, and deep burial. That's very, very important. And centralized biomedical waste treatment facility, CTF, as I mentioned to you. So this is all that I thought I'll share in my presentation to classify the waste, to tell you that it's only small percentage of the waste which is very dangerous. Then the importance of the liquid waste management, effluent treatment plants in the hospital, and then finally the sharps management, as well as some disposal options. I think I will also request all the participating regional centers, including the students, those who are sitting here, that they must clarify their doubts, and they must ask the questions intermittently, and you can interrupt us anytime that you feel like. And now I will request Mr. Alexander von Hildebrand. I call him Alex, affectionately, and he calls me Ashok. So if you give us the liberty, we'll call each other by this name. And so Alex, they are very eagerly looking forward to your presentation, and please enlighten us on your presentation. Thank you, Alex.
Thank you, Ashok. I will go there and sit over there,
Okay, please,
there where you are.
Please. So I'll be.
So, good afternoon, all of you, students and regional center authorities. It is certainly a pleasure to be here once again. You have heard from my friend Ashok in broad terms actually what makes us think that we need to have much more knowledgeable people on how to promote sound ways of managing hazardous wastes, and especially wastes from healthcare facilities. I have a small presentation I would like to share with you. It is also quite a general presentation, and I will keep this short in order to get questions from your side, but I will insist a little on the legislation part, especially in the whole of the Southeast Asian region. As Ashok was mentioning to you, the classification of wastes is very crucial, and we need to understand that this is not only a situation that concerns each country. Actually, the UN Convention on the movement of hazardous wastes, called the Basel Convention, has very much looked into hazardous wastes and has classified them with these codes: Y, Y2, Y3, Y4, Y5. So yourselves, you can see that pharmaceutical wastes are considered to be very, very hazardous as Y2. Y3, again they come up. Y4, we see there biocides, which actually stands for pesticides. And then we have chemicals, especially the wood preserving chemicals, which are on Y5. But what is very important for you is that this global UN convention considers clinical wastes to be the most hazardous wastes after nuclear wastes. This convention does not look after nuclear waste, so for them the most important priority, top priority, is clinical waste. This picture shows you why. This picture taken in Nepal shows you that a person there is trying to find something to maybe to recycle, to reuse in this mountain of garbage mixed with medical waste. As Ashok was mentioning to you, sharps is the most important, the most hazardous within the medical waste. And this is a very sad picture you can find in many places in the world today, where we have large amounts of syringes being used. WHO considers that the big majority of injections are not needed. Especially therapeutic injections can be easily replaced by other medication, but still we have mountains of syringes, used syringes, that pose these kind of challenges.
This is the one, yeah.
We're talking about India, we're talking about the region. In the region, the Southeast Asian region, we have 11 countries with a total population of about 1.7 billion people. And you would be surprised, but it is a fact that every day there is a production of about 1,500 metric tons of waste from healthcare facilities. Now, as again Ashok was mentioning, most of these medical waste is not segregated properly, which means we have to consider the whole amount as being infectious. To tackle this, only a few countries have legislation in place. So we can see here the amounts of metric tons. Year 2000, we're in 2007, when we should go for a new survey assessment. Probably it will be just a little more, but you can see the amounts, the amazing amounts of tons per year that are produced in each one of these countries. As I was mentioning, India, Thailand and Bangladesh maybe also Sri Lanka, these 4 countries have a legislation that is functioning, let's say, but other places have absolutely no legislation at the moment, and that is a big challenge for us. This picture is taken in Nepal. This is the top roof of a hospital. So you can see how they are handling their waste. Now that gentleman was told to be careful, or maybe he thought himself, and he thought to wear these gloves would help him. But he must be inhaling the toxic fumes here. Probably he is burning plastics there. And as you can see, the whole idea there is not of a sustainable system. It is done ad hoc with the least of investments possible. So this is a typical situation in many of the countries in the region. This picture is very famous, taken by a friend in India, where not only the person is not aware, but it has been completely wrongly informed, because by putting that motorcycle helmet, he's not protecting himself. On the contrary, should the smoke enter the helmet, he'd be even more exposed, because the smoke will be accumulating inside the helmet. So all these messages are still to be communicated in the proper manner. It is not only the waste manager who would be at risk. Everybody along the whole chain of, since we can look at wastes being first produced, then stored, well, produced, segregated, stored, transported, then reused, before maybe disposed. All the people along that life cycle are exposed. And at the end of the day, it's you and me that are exposed. This is why we need to do something. The issue of mercury is a very important one. Has not been highlighted as much as it should. We have mercury in thermometers, and it is very much possible to replace those thermometers and other medical devices with such ones that do not contain mercury. In the same way, you have seen that picture with this gentleman on top of the roof. You would see pictures of nurses picking up the mercury balls from the floor, just as if, maybe with a cloth or something, completely unaware that they are exposing themselves to mercury fumes. And then where to put that waste? That is not yet understood correctly. And please do refer to the book to understand this. Maybe Mega can say a few more words on this particular issue of mercury. In general, we are very much pushing within WHO for mercury-free devices. We have now issued a very clear statement, a policy paper, that I would encourage you all to go and check out. Should be there by end of this month on the who.int website. Go and check for mercury paper. That would be giving you maybe some support also in your own work if you are trying to reduce risks linked to mercury and mercury spills. Coming to the legislation part, can I have the slide? Thank you. Yes, you can see from these countries that we have listed, India being the senior in terms of legislation. Actually, India can look back to 1974 with first laws on water quality, but actually some of the states had already started this in the 50s. It is not only because of goodwill that it came to 1998 with the biomedical waste handling and management rules. It is also because there was a lot of pressure from NGOs, from social society. These rules, BMW they call them, were then reviewed, and I think there were addenda in 2000, 2002. Anyway, these are the rules in India that we have at the moment that need to be implemented. I understand that up to now, latest figure was 15% of healthcare centers in India are actually implementing those rules, which doesn't seem to be much, but it is a lot. From 0 to 15, it is a lot. We're looking back 10 years now soon, so it's very encouraging. And I would like to share with you that definitely in all neighboring countries, they are looking at what India is doing. Bangladesh has a lot of elements for a national legislation. It just needs to be now all these elements brought together in a coherent fashion, and the national law probably will be passed before end of this year. The challenge is, of course, here that we have several sectors that are involved. Waste management belongs to Ministry of Environment. Of course, Ministry of Industry is involved. You have Ministry of Chemicals here. At the level of various ministries, but then again, municipalities are involved. So many agencies being not used to coordinate their action shows you the difficulty of having a legislation that stands well. So we are also pushing through our own offices in the different countries, and we again this year we offered support to each one of the countries to come out with more to produce more at the level of legislation. Having said that, legislation is not the only thing we need. We need legislation. We need legislation, as we have red lights and green lights, but still people jump lights. So we should not confuse ourselves. The human element is very important. The human element. So even in settings like Myanmar, where you can see no legislation at all, in other countries like Bhutan, still not much happening. There are isolated initiatives that we really like to promote, because the basic element here is, of course, motivating the staff at the particular health center so as to get an understanding that by organizing ourselves and promoting hygiene, sanitation within the healthcare center, we can reduce all these risks posed by medical wastes. So as we are working on promoting legislation, we also need to work on training and capacity building, and this is why we are here today. Just let me share with you the tsunami experience in Indonesia on how we promoted. We actually had an opportunity to help some 40 health centers to be rebuilt, and immediately we used the same contents that you are having now in your certificate program to train over 500 workers in Indonesia, in Aceh, and after 1 year we had helped them to set up full-fledged systems, non-burn systems that we are now in process of evaluating. So again there, although the legal framework is not perfect, is not there, we're working on it, we still think it's necessary to continue with our capacity building. So you can see here where we had this one of the districts where we were carrying out this capacity building.
Banda Aceh is the place where the tsunami originated, isn't it?
Yes, yes.
Yes.
That's where the tsunami hit most, killing
Yes.
something like 300,000 people, destroying completely the city, several cities. So we managed to help them build up again the health system, but this time with a proper management of the healthcare waste. My friend was mentioning pharmaceutical waste as being also one of the hazardous wastes. Again, that was very much a case in the tsunami situation. We should not forget that part. We should know that there are also rules how to deal with obsolete or outdated pharmaceuticals. I'd like to refer to your book. Take a good note of this very important element. The risks posed by outdated pharmaceuticals are not only that they may cause environmental pollution because diluted, because here you can see maybe drained. No, the main risk hazard is that people will consume these outdated drugs, and maybe those drugs have changed chemically, but also they will certainly not be effective. Coming back to where I started from, you can see in a situation again where we have no implementation whatsoever on segregation. In this particular case, that gentleman is burning plastic wastes that have accumulated. Again, this picture is from Nepal. So I want to point out the urgency for action with this picture. So what I want to ask you, my friends, and I'd like to congratulate you all for having taken this course. Together, let us act together for safe environments and sustainable human health. Thank you very much.
Thank you. Thank you, Alex. Thank you very much for the excellent presentation, and then giving an overview of the legislation, the regulation which is there. You know, what is the current situation, because as he mentioned, there are only few countries which have got the biomedical waste management rules in place, and luckily we are one of those countries. We may have the rules, but how the rules are implemented is the big question, and that's what Alex has tried to point out, that you have the traffic signals, you know, the red light, the green light, and then even then we violate that. So probably we are violating the rules left and right in this country, and probably you know, the implementation in the hospitals, even in the city hospitals or the corporate hospitals or the metro hospitals, you know, is also very tardy and very superficial. So I think you have got a perspective of the Southeast Asia region. There are still, as you said, Myanmar has no rules, and there are many other countries also who has to come up with the rules. Now, Alex, if the rules are violated left and right, how should we go about it? Because in this country we have got at the center the Central Pollution Control Board, then we have got the State Pollution Control Board. Why is it that things are not improving?
Well, look, Ashok, one of the challenges, of course, is, as I was saying, many agencies are responsible.
Yes.
So, as in the case here in India, it is the Ministry of Environment that should be, you know, the watchdog for the implementation of the law.
Yes.
Now, they are maybe not as knowledgeable as would be needed to be effective in implementing this. Another one is, historically, many of these laws, legislation has developed by putting together bits and pieces from other sectors, from other periods. So you won't be surprised that often the penalties
Yeah.
that people would suffer if they don't respect the law are not very important. Maybe they are 5,000, maybe they are 10,000 rupees. So for a manager of a hospital, well, you know, I prefer now and then maybe to pay my fine, and I don't have to set up the whole system, right?
I think, yeah, Alex has made a very important point. We are going to close the first session. The point that he has made is that there should be more stiff penalties, and to the extent that probably the hospital may be given a very serious notice that you will be locked out, or there will be, you know, the institution will be locked out, or there will be imprisonment for the hospital management. I think those kind of punishments have to be brought in.
They're in the rules, but
they're in the rules.
They're already there.
That is already there, but probably the implementation, Megha,
is very poor.
So with this, I think we wind up the first session here. and we'll be back at 3:45 sharp. So please stay with us and prepare the questions, because we have not heard any questions from anywhere, and we will request Megha to take on the session after the tea break, and then we hope that we'll have good interaction with you. Thank you very much.
Thank you.